Hi. I too did not look at the case presentation before doing this, and James was my junior resident, and he was always discontent. This is very, very typical that he, what was that terminology of the patients who received surgery that they didn't want? That seems, yeah. So, and thanks, John, for inviting me to come to CAS this year and speak. John and I were interns together, trolling the halls of San Francisco General Hospital, and he was actually, I think, on your orthopedic internship rotation with me, and so those are fun days. I have a very unique private practice in San Francisco, where most of my cases are outpatient, minimally invasive, motion-preserving surgery in young, healthy individuals in San Francisco that really, really don't want a fusion. So yes, there's definitely bias going into the surgery, and partly I've had to modify my what surgeries I offer to this population to meet their needs. So there are a lot of similarities in the patient population, the clinical presentation, the decision for surgery, surgical indications, and even the bulk portion of the actual surgery itself is very similar, but really we can't lose sight of the fact that they are two very different surgeries. So in the ACDF, you are locking up that motion segment and there is no motion there. In the TDR, it's not perfect, as James has so eloquently pointed out, but there is still motion, and it allows motion in a different way at the adjacent segment. So this is a key difference that will translate to the overall outcomes and the consequences of the two different surgeries resulting in different outcomes. A dozen years ago or so, when the total disc arthroplasty first hit the scenes, there was this biomechanics study that measured the intradiscal pressure and the motion at the adjacent segments in an ACDF versus a total disc arthroplasty. And essentially, there was no change in intradiscal pressure and motion in an adjacent segment to a total disc arthroplasty. In the ACDF, there was increased intradiscal pressure by 58%, increased motion of 48%. So that's pretty significant when you look at it, even if it's not the actual biological tissue that mimics a disc. This device does not create any additional pressure on the adjacent segments, and this translates to the future outcomes of these two different surgeries. And then leaving the biomechanics aside, this is great data, and you can slice in the different biases here and there, but there's no other medical device or technology that even rivals the amount of patients enrolled across multiple sites, multiple surgeries. Multiple surgeons, multiple devices, and they all are coming out with the same results. So now we have 5, 7, and 10-year data to analyze. So I won't go through every single study. There's a lot to look at and little time here, but there are basically 4 areas where the total disc replacement is superior to ACDF, and this was mainly in the faster return to work, higher NDI scores, overall lower complication rate, and lower incidence of adjacent segment disease. So we'll just kind of look at the mid and long-term reoperation rates. The ACDF itself is already disadvantaged in that there is a risk for pseudarthrosis at that index level. So when you look at just the overall reoperation rate for one-level surgery and two-level surgery for ACDF and total disc replacement, there's already a huge difference and disparity in those numbers. So then when we take that out, that pseudoarthrosis at the index level out, and we purely look at the reoperation rate for adjacent segment disease, those numbers are still very compelling. And bias or no bias, it's happening. So we've taken a great surgery, which is the ACDF. We now have a lot of data, and for years and years we're thinking this is a great surgery, but now we're actually able to follow these patients over a 10-year period very critically, and these are the numbers. Everyone thinks that they have a great ACDF fusion rate, but when you look at this data, the 1 year, the one level ACDF fusion rate can be as low as 85%, up to 97, 98%. We all want to believe that we're there at the 97, 98%. When you take a two-level ACDF, that drops down to 80% of fusion, fusing both levels. And then if you take a three-level ACDF, it goes down to 65% to 85%. So then here's a recent meta-analysis. There's just so much data now. There's 14 RCTs, over 3,200 patients with 2 to 7 year follow-up data. And when you really look at just purely the rates of adjacent segment disease and then surgery for adjacent segment disease, it really, really favors the total disc arthroplasty over ACDF. And then here's now the first report of 10-year data. And, you know, if this was my 10-year data, and I can look back and honestly say I had one patient that needed surgery for adjacent segment disease in my total disc arthroplasty group versus 6, that's pretty compelling. It wasn't statistically significant because of the small sample size, but as a clinician, if this is you're looking at yourself pretty critically, this is again very compelling data. Then I tried to track down Dr. Bay, who has presented his Mobi-C 10-year follow-up single-site numbers. And again, he will say there's no surgery that he's done at the adjacent level. And the x-rays themselves of all of his patients are very compelling when you look at especially the two-level cases, that there is really a huge difference between a two-level ACDF and a two-level total disc replacement, which will be favorable for my case presentation debate. So then I didn't really think that this was much of a debate. This is definitely an interesting topic. I thought I pretty much had it already in the bag to keep it interesting, and this is off-label use. But I wanted to say, I think it's an application that we can really look to helping us in areas that have been traditionally problematic. So in older patients, spondylotic myelopathy, there are a couple of smaller studies that have indicated that this could be beneficial for the same reasons that a laminoplasty is successful. We may not have to lock these down and fuse them. And then Dr. Rue also looked at this early on with the Brian and the Prestige patients who had myelopathy, had all favorable outcomes with this surgery. And then perhaps using it as an option to treat adjacent level disease after prior ACDF rather than taking the plate out and doing a massive revision fusion to a 3-level fusion, and then hybrid constructs for multi-level disease, so that you essentially take a 3-level demand for fusion, reduce that down to that of the 1-level ACDF, and then you're also preserving motion at the adjacent segments. So thank you. And it was just really nice to see the women get the job done. Thank you.